Okay, this is Dr. Richard Davis coming to you from Geisinger Emergency Medicine Sports Medicine Program in Central Pennsylvania. This lecture will be on musculoskeletal ultrasound in the critically ill. Goals and objectives for this lecture is overview of musculoskeletal anatomy. We're going to go over technique and probe selection, images, a number of images and cases we're going to go over. We're going to go over ultrasound and the evaluation of septic arthritis and bursitis. We're going to go over some specific sonoanatomy, including bone, tendon, ligament, muscle, and fluid images, some basic pathology, and some common musculoskeletal joint aspirations and some pearls and pitfalls that you may come across during specific procedures. So I'm going to take some time right now to go over a few of the myths about musculoskeletal ultrasound. Some people think it takes too much time, it's user dependent, it may have limited resolution and image quality, could be costly, and limited musculoskeletal application. Some musculoskeletal terminology that is important to know. One thing that is very common that we talk about in musculoskeletal ultrasound a lot is called anisotropy. It's very common with tendons and ligaments. So basically what we're looking at here is when you have a normal hyperechoic tendon. This is the anterior talofibular ligament. This is the fibula. This is the talus in the ankle. When it becomes hypoechoic, when oblique to the sound beam. So right here. The way that you eliminate that is by heel-toeing the image. Heel-toeing the probe and looking at the image in different sequences to make sure that there is no tear. Some different scanning principles that we'd like to go over. You want to scan your structure in short and long axis. You always want to start with bony landmarks for picking up your orientation. And then you want to obviously eliminate artifact, and this is common with, very much commonly so with anisotropy. And you want to characterize your pathology. You want to follow well-developed protocols. And in order to do a really good musculoskeletal ultrasound, you really need to know our anatomy. So just a quick review on axis. I'm sure most of you guys are already aware of this. Longitudinal axis, long axis to the tendon. So this is in regards to the biceps tendon in the shoulder, right here. This is long axis. Right here. Right here. In relation to short axis right here. So here's a short axis view, and then a long axis view of the tendon right there. This is the supraspinatus tendon. Image appearance. So what do different structures look like? So a muscle is going to have a pennate appearance like this because you have myofibrils. A starry night appearance is more with a tendon, and you have much more pennate a much tighter pennate pattern, such as here. Ligament is a very compact, more fibular pattern. Here. And nerve is more of kind of like a grape-like appearance, more of a striated fascicular appearance. So here's an image of the carpal tunnel with a, obviously, nerve, the median nerve. See how it is kind of more dark and hypoechoic compared to your Achilles tendon here. This is the Achilles tendon in short axis, Achilles tendon in long axis with the calcaneus, remember, bony landmarks. And here is the median nerve in long axis, along with your carpal bones. Tendons, like I said, they're in parallel series of collagen fibers. They're more hyperechoic, and they're separated by darker hypoechoic surrounding connective tissue. So here's long axis patellar tendon. Here's our biceps tendon in the intertubercular groove. Image appearance of bone, obviously hyperechoic. This is the femur. This is the trochlea. image appearance of muscle is a little more echogenic structures. They're seen as bright linear bands, feather, or veins on a leaf appearance. So here's the vastus lateralis. The nice thing about musculoskeletal ultrasound is you can have dynamic imaging applications to it as well. You can put your ultrasound probe over the area of interest, and obviously if there's an acute fracture and or muscle strain, you can look over that area of interest and you can have patient feedback. With a tendon tear, you're usually going to have volume loss, and you're also going to have accentuated with patient contraction. With ligamentous stress, you can test different ligaments. One common one is the UCL of the elbow. Another common one is the UCL of the thumb for a gamekeeper's thumb. You can also compress, so you can look at fluid, joint fluid usually compresses. You can also look at synovitis and synovial proliferation, which is more minimally compressible. With synovitis and synovial proliferation, these are more in your maybe rheumatoid arthritis or autoimmune diseases. Then you can also look for impingement, such as here in the subacromial bursa. You can also look at muscle injuries or contusions. One common muscle injury, you can have a high-grade strain or tear, which you can develop a hematoma. You can also develop a hematoma, obviously, from direct trauma. It's great for use in critical care to distinguish a hematoma versus an abscess. A hematoma will typically be more hypoechoic or isoechoic, whereas an abscess will be more hyperechoic. Here's a deep space abscess of the hip joint. This is an ultrasound image in long axis of the femoral neck, which shows an isoechoic to a hypoechoic anterior joint recess distension right here. And note a cortical irregularity here as well from a femoral head and neck erosions. Then the other nice thing that you can do is you can do color Doppler, and which we may show hyperemia, which is also indicative of an infection. Tendon injuries, very common. Here is a tendon injury of the supraspinatus tendon in long axis. Here's the tendon, and then here's your tear. This would be diagnosed as a full thickness tear from the articular surface down here to the bursal sided surface up here. And then here as well, this is a short axis view. Here's an intrasubstance tear. Obviously, it's very easy to see a fracture as well with ultrasound on superficial bones. You will see cortical disruption. You can see a hypoechoic signal adjacent to the bone, and you also see increased flow on the Doppler. You can see certain nerve entrapments, a peripheral nerve. Most common ones for us that we see in sports medicine or in the emergency medicine would be the median nerve, which would be consistent with a carpal tunnel syndrome. Here is a beefy, kind of large, hypoechoic area of a median nerve. You can see it's very swollen. And here's an ulnar nerve in the cubital tunnel, which is also quite swollen. Soft tissue masses, very common as well. A lipoma is a homogeneous and oval hypoechoic area. Sometimes it will be isoechoic. You will have little or no flow on color Doppler imaging. It will oftentimes be soft and pliable with transducer pressure. Usually there's minimal fluid distinguishing it from an abscess or hematoma. Soft tissue masses, also very common. Ganglion is usually hypoechoic or anechoic. It can be multilocular or multilobular. It's a non-compressible cyst that may look complex. There's usually minimal or no flow on Doppler. Now we'll go over some more of the common joints, since we went through kind of some basics of musculoskeletal ultrasound anatomy. The knee anatomy, obviously, we see a lot of knee injuries in the ER. Knee is also a very common area to get a septic joint, and it's a very common area that's very easy to see for a knee effusion. The most common place to get a knee effusion is in the suprapatellar recess, or the suprapatellar bursa, right in this area. A Baker's cyst is right here, which is cyst-filled area behind the knee, which you can get an outpouching of if there's meniscal degeneration. Here's a large Baker's cyst, and then here's joint fluid distension right here. So how do you evaluate the knee joint? I usually have the patient supine, knee slightly flexed. A lot of times I'll put a towel roll under the popliteal fossa. That kind of helps distend the joint slightly and will help you better define the fluid if there is any. The primary structures you'd like to evaluate are the quadriceps tendon, patellar tendon, the patella, the suprapatellar recess, which is the most important place for an aspiration, the infrapatellar tendon, and for most people we use the linear probe. Quadriceps tendon in long axis, quadriceps tendon, suprapatellar recess is right here, there's no joint effusion, and then here's the patella, here's the femur. A knee effusion is going to be seen this way, so here's long axis, joint effusion, prefemoral fat pad, femur, quad tendon, and subcutaneous fat. And then to the right here, here's another good picture to orient you. Here's a ultrasound of a knee effusion. Here's how I do almost 99% of my knee effusion aspirations. I usually use the suprapatellar lateral approach. The suprapatellar lateral approach is the easiest approach in my opinion to do. Most commonly, the fluid will pool more laterally, along with the hip or the knee and slight bit of external rotation will help this as well. There's also the least amount of muscle in that area. The vastus lateralis is the smallest quadricep muscle, so you go through the least amount of muscle, and there's no nerves over there that you're going to disrupt. Here's the needle coming in long axis view from the side here, and then here's your needle here aspirating the fluid. Some pearls and pitfalls just to remember. There's no major vessels or nerves in this area in the suprapatellar lateral knee approach. This is one of the reasons why I prefer this approach. Also, sometimes what I will do is I will go a little bit more lateral and flat more than a medial steeper approach. Coming a little bit more laterally and flatter, you get a better angle of attack. Some pathology of the prepatellar septic bursitis. Also another very common thing we can see in the ER. Here's a prepatellar bursa, multiple septations. So we call this a mixed echogeneity septal pattern. There's hypoechoic fluid containing some debris. This will a lot of times be warm, hot, and this is more anterior knee pain on exam. A prepatellar bursa aspiration. Put the probe right on top of the kneecap, come from the side, and aspirate. Very easy to do. I'm going to use a linear probe, and I will go long or short axis in this view. Some pearls and pitfalls. Just remember your anatomy. Your prepatellar bursa is in the prepatellar area. It is going to be anterior knee pain. It's going to feel hot. It's going to feel warm. I always say this. I know it sounds simple and dumb, but you want to go where the fluid is. There's not many complications with these, but consider an ortho consult beforehand. Where I practice, a lot of times they like to place these patients on antibiotics first and see them in follow-up clinically. Most of the sports medicine and knee surgeons that I work with, they typically will try not to aspirate a prepatellar bursa if they can, because there's a high rate of infection with them, and B, there's a high rate of seeding the bursa that could potentially be inflamed and you could make it worse. So most of the orthopedic guys that I work with will honestly just put them on antibiotics and see how they go. But that's probably kind of dependent on where you work. So one of the common things that we'll come up with is a difference between a bursitis and a septic arthritis, especially in the knee. I think it's probably one of the most common joints that we'll see this in. So a prepatellar septic bursitis really depends on your anatomy and your physical exam. You may have a better ability to flex and extend the knee and bear weight, and the prepatellar bursa is much more common to have anterior pain, swelling in the prepatellar fluid. Whereas your knee joint septic arthritis, that's where your patients are typically going to be much sicker. They might be septic, and they rarely have any difficulty bearing weight, and they really can't do any range of motion movements. The knee septic arthritis patient is usually sicker. A lot of times they'll have a fever, they'll have more systemic signs and symptoms, and the big thing is they are really just unable to move the knee. Whereas a lot of more people that I've seen with prepatellar bursitis, they still have the ability to flex and extend the knee, but they just have a lot more of that anterior knee pain. Anatomy of the hip joint. So now we're moving on to the hip. The hip, a very important joint for us to know a lot about. I think one of the most important things is just go over the anatomy of the hip joint. So here we are here. This is in a long axis view with a curvilinear probe. This is our hip joint, and you can see our hip joint capsule right here. Femoral head, acetabulum, and then this is our femoral neck. Here's our medial circumflex femoral artery, our ligament of the head of our femur, and our acetabular fossa, and our membranes. So here is a question for us. An 18-month-old child has been brought to the emergency room by his mother. He had sudden onset of hip pain 3 days ago and now won't put any weight on the affected limb. The child is febrile, and an ultrasound, longitudinal view of the proximal femur is shown in Figure A, shows the unaffected hip on the left and the affected hip on the right. The patient is taken to the operating room for hip aspiration, which reveals 60,000 leukocytosis with 95% polymorphonucleocytes. What is the most likely diagnosis? So here's our ultrasound. Acetabulum, femur, joint, acetabulum, femur, femoral neck, and look at this joint joint effusion. So that's what we're looking for right here. And you can compare these side by side. Normal, abnormal. So the nice thing about the hip joint, or really any joint, is you usually have two of them for the most part, and you can compare side to side. So this is a diagnosis of septic arthritis. So some key things in this stem: won't put any weight on the affected limb is definitely concerning. An ultrasound shows an obvious joint effusion, and then the hip aspiration shows 60,000 leukocytes and then 95% polymorphonucleocytes. So some key concepts for hip septic arthritis. There's risk for long-term damage if not caught early. I feel like the most common people we see these in, at least in the emergency department or in critical care, is going to be the hip joint in a pediatric patient. So we definitely don't want to miss these. There's long-term damage if not caught early. It's a surgical emergency, and it's the second most common location after the knee, but you're much more likely to have bad complications from a hip than a knee. Patient positioning and probe selection. So the way you're going to aspirate this joint is in the supine position. Your hip is going to be in neutral or slightly externally rotated position. In most people, you will be using a curvilinear probe unless you're very skinny and young. Hip anatomy. So hip anatomy, again, very important. Here we have our vein, artery, nerve. Go by the navel from medial to lateral. Hip joint aspiration or an injection. So your transducer position is curvilinear, and you do an anatomically transverse oblique plane. Same plane as the femoral neck over the femoral head and neck area. Your needle orientation is going to be relative to the transducer. You're going to have a long axis, longitudinal, in-plane approach, and you're going to go from inferior lateral to superior medial. Your target is going to be your anterior joint recess at the femoral head-neck junction, right in this area. So between the femoral head and the neck. The joint capsule extends all the way from here to here. Pearls and pitfalls. you want to obviously locate and avoid the femoral neurovascular structures, the femoral nerve, the artery, and the vein. Here's an obvious hip joint effusion. So on this sort of ultrasound, what we're going to be doing is we're going to be coming from here to here. We're going to be aspirating the fluid right here. Another good diagram of a hip effusion right here. Joint capsule, femoral head, femoral neck, and our effusion right here. We usually say anything greater than 5 millimeters is indicative of a hip joint effusion. Here's another diagram of our aspiration for our positioning. Here's our joint, so here's our femoral head. Here's our femoral head, neck, and here's our needle going to the femoral head-neck junction to aspirate. Here's our positioning with the curvilinear probe in an oblique transition point to that femoral head-neck junction right there. Some hip aspiration pearls and pitfalls. So obviously we want to locate and avoid the neurovascular structures, the nerve, the artery, and the vein. What a clinical pearl for myself is I'll start out kind of like the knee. I will start out further lateral, and this requires a less steep angle. It also gives you a better positioning to the femoral head-neck junction, which is the most common place to get that effusion. And I feel like this even helps you avoid the neurovascular structures even better. Ankle. Ankle aspiration is most commonly done with an anterior approach. Ankle is a common joint for more. The patients that I'll see with more ankle joint pains and ankle effusions is going to be more of your gout patients. Gout, obviously, the most common joint would be the MTP joint, but I do see a fair amount of gout in the ankle joint as well. So it's good to have this one in your arsenal as well. Here's your normal ankle joint, your tibia, your fibula. Here's a fat pad. Then here is our ankle effusion. Here's how I will do most of my tibia talar ankle aspirations. I feel like this is the easiest way to do it. You're avoiding any neurovascular structures in this area. Long axis, needle. I'd use a fairly flat probe, and I'll come right in. Needle path is going to be right here. Like I say, for every aspiration, you're going to want to go to where the fluid is at. Ankle aspiration pearls and pitfalls. You want to avoid your dorsal pedis artery. It's very easy to see on ultrasound. You also want to make sure you plantar flex the ankle joint to open up that joint space. I will always say don't expect to get a lot of fluid out of the ankle joint. A lot of times in an ankle you will see a lot of fluid, but in reality it's actually only 1 to 2 cc's. Shoulder, another very common joint that we will aspirate or inject. I think one of the most common procedures that we'll do is for a frozen shoulder. Frozen shoulders, adhesive capsulitis can be very painful. And one of the first places a lot of times people will go will be to the ER because of the pain. If someone has a shoulder and they're not moving it very well, maybe they have a history of diabetes, hypothyroid, and they have a lot of pain, one of the first things I think of is a glenohumeral joint adhesive capsulitis, also known as a frozen shoulder. The way that I will do a shoulder glenohumeral joint aspiration, I have the patient lying on their side, and I have the probe in this position right here. Depending on the size, I will either use the flat or the curvilinear, like I said, depending on their size. And then I go from a medial to a lateral approach. Here is our anatomy, head of the humerus, the glenoid, and the deltoid. And here's our infraspinatus muscle. Here is a good diagram of a glenohumeral joint aspiration with an effusion. Joint effusion, humeral head, glenoid. Normal, joint effusion. Ultrasound guided aspiration is going to go right to this area. So you're going to go right to the humeral head glenoid area where the fluid is. Glenohumeral joint pearls and pitfalls. Lateral to medial approach is what I will typically do. You want to enter flat. Sometimes you'll have to go steeper. I have the patient lying down on their opposite side, which is a much easier way to approach. Elbow olecranon bursitis, another very common thing that we will see in the emergency department. Bursitis, inflammation in the bursa. This is what it will look like on ultrasound. This is the ulna. This is the bursitis. Elbow olecranon bursitis, differentiation between elbow septic arthritis. Sometimes difficult to do. However, with a few key tools, I think you'll be able to pick this one up pretty well. In elbow olecranon bursitis, your bursa is going to be very distended. It might be red, and you will still usually be able to flex and extend the elbow slightly. The fluid will a lot of times have septations and increased flow, whereas elbow septic arthritis, usually a very, very limited range of motion, and you also have no swelling posteriorly in the bursa. So here is a good diagram of a triceps tendon, our trochlea, our olecranon fossa, and here's our joint. Our elbow olecranon bursitis, aspiration pearls, and pitfalls. You want to stay as midline as possible. This will help avoid the radial nerve. I like to have them lie down, and an elbow with some flexion will help the bursa distend. So here's the patient is lying down, their arm off the side of a bed, and this is the way that I do them. Septic elbow arthritis. So septic elbow arthritis, this is actually a case that I had recently that was submitted for publication. With a septic elbow arthritis, you're going to have much more pain, worsening with flexion and extension, or a very, very limited range of motion with flexion extension. Here's our olecranon, here's our effusion, here's our fat pad, here's our tricep in this area. And then here is our needle going into the synovial capsule with the olecranon and the humerus. Here's another view right here. So summary, musculoskeletal ultrasound anatomy, we went through our basics. We went through basic pathology. We also went through an evaluation of some soft tissue masses. We also went through some interventional arthrocentesis and of some common joints, and went through some common comparisons of septic bursitis versus septic arthritis. I think the most important thing to remember from a critical care standpoint is the physical exam for septic bursitis versus septic arthritis. With a bursitis, the patients usually are not as sick. Well, I think the most common bursitis we're going to see is going to be the olecranon bursa and the prepatellar bursa. In these patients, the pain is going to be more superficial, more anterior. Whereas in a septic arthritis, patients are going to be much sicker, systemic signs and symptoms. Also limited range of motion of the joint, along with more pain with any sort of weight-bearing activities. For example, standing in the knee, and any sort of weight-bearing activities with the elbow is going to be much, much more common. I think the best way to get better at interventional arthrocentesis of some of these joints is practice. I will do a lot of musculoskeletal ultrasound in my practice to look for joint effusions. I will do a lot of musculoskeletal ultrasound to look at the patella tendon, quad tendon for quad and patella tendon tears. These are things that are very common that presents to the ED as well. So these are the things that I'm going to be looking for when I'm doing a physical exam. And I think the musculoskeletal ultrasound is basically kind of augments my physical exam when I'm doing a lot of different joint exams in the ER. When I'm looking at either the shoulder or the knee or the hip, the musculoskeletal ultrasound will really kind of be an extension or kind of the fifth arm of the physical exam. That is all I have for you today. Thank you very much for your time.